Hey everybody, Dr. Quirk here with your case of the week. So this is a young patient who presented to the sports medicine clinic with a complaint of knee injury. So we have some femur radiographs here. We have AP radiographs of the proximal and distal femur, and we can see that there is some mineralization within the what looks like it's in the femur on the AP here and kind of extending into the lateral soft tissues there. Here on the lateral views, if we focus in on the distal femur, we can see that it's actually not within the bone itself, but it's actually posterior. So we have a matrix producing tumor. You have three different versions of matrix. You can have osteoid matrix, you can have cartilaginous matrix, or ground glass matrix. So in this case, we have actually some osteoid matrix because it looks like it's trying to form actual bone within the lesion. The other thing I want you to notice is we have a soft tissue mass associated with it, and then there's this kind of stalk of bone production here along that appears to contact the posterior cortex. There's not really any cortical destruction, and there's nothing actually in the femoral medullary cavity, it doesn't look like. So this kind of helps us in our differential here. Here's the arrows kind of showing you guys what we're talking about here if you couldn't see my cursor there. We know this is osteoid matrix. We have a stalk within it, so we need to come up with a differential here. Heterotopic ossification could be within your differential. The thing about heterotopic ossification, though, is that it typically ossifies from outside in, whereas this looks like it's going from inside out. So this looks more like it's probably a tumor of some sort. And if we think it's a bone-forming tumor, we have osteosarcoma within the differential. So that's actually what this is. This is an osteosarcoma variant. So this is a surface osteosarcoma. Surface osteosarcomas are broken down into periosteal versus parosteal osteosarcomas. So it just depends on where it comes from. They have slightly different imaging appearances too. The periosteal osteosarcoma comes from the inner layer of the periosteum, whereas the parosteal comes from the outer layer of the periosteum, which kind of gives it this characteristic appearance here that they call the cauliflower appearance. The parosteal is more common as well. It's about 5% of all osteosarcomas versus less than 2% for the periosteal osteosarcoma. So for parosteals, usually it's going to be kind of posterior femur in the metaphyseal region. It's going to have this kind of classic stalk that connects it to the bone surface. The good thing about these is they're usually low-grade tumors and they only require resection. They may not require any radiation or chemotherapy, and they have a good long-term survival rate in the 90% range. These usually they can just kind of cleave them off the posterior cortex. They can, if they've been around long enough, extend into the medullary canal, and in that case they might have to do a limb salvage surgery that you guys see where they get the knee arthroplasty and endoprosthesis, but most of the time they can be kind of just pulled off the back of the femur there and have good results. Comparing that to the parosteal to the periosteal is actually more cortically based since it arises from that inner layer of the periosteum. They also tend to be more diaphyseal. Here's the image from a case that I pulled from Radiopedia, but this will be a more broad-based lesion where you see a lot of cortical surface erosion. And these, the thing to know about them is they're a little bit more in the intermediate grade range, so they have a better long-term prognosis than conventional osteosarcomas, but not quite as good as the parosteal. So if you guys have any questions, as always, you can email me, but thanks for listening in.